Good morning, everybody. Great to see everybody. Welcome to Grand Rounds. It's my pleasure this morning to introduce our speaker, Dr. Varina Boerwinkle. Dr. Boerwinkle is an associate professor of child neurology at U of A in Phoenix and is the director of neurocritical care and director of functional MRI and neuroscience laboratory at Phoenix Children's. She is a native of Texas. She completed medical school at UT Southwestern in Dallas, and then a residency in pediatric neurology at Baylor College of Medicine in Houston. She started her career at Texas Children's, then moved to PCH in 2017. She's highly published and has spoken nationally and internationally on the topics of resting state functional MRI and in the field of epilepsy and disorders of consciousness. Please welcome Dr. Boerwinkle.
Thank you all for coming this morning to hear about a topic that's near and dear to my heart. And I'd like to point out that we have a special guest, Mrs. Christy Gibbons today, who is a mother of one of the children who received a resting state functional MRI in our ICU for a time period when her son had a disorder of consciousness. So hello. And so I'd like to get started. First of all, I have no disclosures. And I'm just going to define what is resting state functional MRI. So in a functional MRI, we use a regular MRI machine, and what we can see is all of the major brain networks of any individual who can lay still enough in the MRI channel. So what you're looking at here is a motor network of a human, and this is the same motor strip from the same motor network that we can detect by any other modality in which a brain network is detectable. And what you're looking at is the oxygen signal of this network over time, down here on the x-axis, and then the oxygen level on the y-axis. So all we need to do to detect all of the major brain networks of any individual is to have them in a regular MRI machine. Typically we do this for about 20 minutes. And we can see the cognitive networks, the language networks, the vision networks, the deep gray networks. And this has been borne out in tens of thousands of individuals, including children and neonates. And at no point in time has it ever been detected that this wasn't true for a human being. So these are just some of those fun facts that it's just sort of easy to get from the standpoint that we don't require the individual to perform anything in the MRI machine. And typically for children, because they have difficulty laying still for 20 minutes at a time, they are generally receiving conscious sedation that is administered through our anesthesia department. And you're not supposed to be able to tell anything by look at this, except that this is a bird's eye view of a typical clinical functional MRI report that is delivered to the ordering physician and is stored in the child's medical record. And each one of those pages is a different brain network which is commented on as being normal or abnormal or missing. So here's the real title of the talk. Should we be using resting state as part of end-of-life decisions in those with coma or other disorders of consciousness? So this is a highly sensitive topic. We're going to discuss the ethics, practice guidelines, and scientific evidence behind this question. So first of all, let's have a very clear understanding of what is the mortality of this condition. Coma for pediatric patients has a mortality rate of 17.8%. And this was published in 2018, and this is based on American data. So when we consider end-of-life care in the ICU, especially for patients who have neurologic disorders of consciousness, there are three situations in which we think about end-of-life care. One is when the patient's actually dying. And in those situations, we are doing our best to save the child's life, but despite all efforts, the patient is dying and passes away. There's not much controversy in those cases because we've already done everything we possibly could and the child passes away. Then there's the sort of the third situation in which a person is of conscious state and is asking to be allowed to pass away. So in these two conditions, is not what we're concerned about during this talk. What we are concerned about is when care may no longer be in the best interest of the child, but they are not actively dying at that point in time, and they're not asking or well enough to ask to be allowed to pass away. And so if we look at the most recent guidelines in this situation for children, what our sort of guiding principle is, what are the what is the quality of life of that child expected to be, and are our interventions expected to alleviate the burden of that illness or not? And in a certain amount of cases, we have a fair amount of certainty of what we expect. So what I'm really here to talk about are situations in which there is uncertainty. And in a fair amount of neurologic cases with disorders of consciousness, there is a great amount of uncertainty on should we continue treatment or should we offer the family redirection of care with priority of comfort care. And so in situations of uncertainty, then we have to take into account the gravity of the decision. And in the situation of disorders of consciousness in which 1 in 5 will pass away anyway, despite our best care, then it's very difficult to determine which of the individuals who are having a serious disorder of consciousness would pass away anyway or not regain consciousness or any meaningful quality of life. The doctors are forced to guess. So the most recent guidelines in regards to how we should conduct ourselves as physicians in this situation sort of point out two ways of going about it. One is a protective sort of approach, protective of parents' guilt or parents' doubts, or protecting parents from divergent opinions on the team, or just protecting parents from understanding that there's significant prognostic uncertainty, or the transparent approach where we basically tell parents we don't know, or we explain to them how much uncertainty there is in this situation. And so which is the best approach? If we look at the most recent guidelines, we are encouraged to take a transparent approach. So if we take a transparent approach, what would that look like? It would mean that we actually discuss all relevant objective information. That would be the exam, the EEG, imaging, prognostic studies, all relevant expert opinions, even if they are divergent. And we would actually discuss our degree of uncertainty and uncertainty. And we would discuss these care options in a bias-free manner. This is actually really difficult. Let me just touch back on what I mean by bias. So bias in practice is we're looking at differences based on the practitioner's perception of what the patient or the families would want based on their gender, age, race, religion, education level, or even biases of the practitioner's personal belief system, degree of care fatigue, and experience level influencing the patient's outcome. And in fact, there's published evidence that our biases actually affect the outcome of our patients. For example, as a woman, if I drop dead in the middle of the street, I am significantly less likely to receive CPR. And you say, okay, well, those are bystanders. They have their biases. They haven't been trained to overcome those biases. What about physicians in the ICU? Well, even controlling for the level of severity of my injury, as a female, I'm more likely to have my care withdrawn than a male. So if we think that our biases don't affect our decision-making in how we approach this end-of-life care, we would be dead wrong. So if we look at this transparent approach, instead of saying statements such as, well, if I were you in this situation, I wouldn't want to take care of a handicapped child for the rest of my life, so I will project those biases onto the family and help steer them away from even possibly having to undergo that situation. Or, taking the opposite approach, all human life is valuable regardless of its condition, regardless of the burden on society and the family, all life should be sustained. Fortunately, if we take the transparent approach, we don't have to choose which side of the camp we are for any individual. We can just present the objective findings, our uncertainty, and then the care options to the family. I'm showing this piece of artwork because it's imperfect. And there's probably not a perfect way of going about this, and no human is perfect. We all have some level of disability. I'm completely dependent on the people who love me. So I think that our differences are where our beauty lies. This is my bias. So what about parents? What do parents want? This is actually a study from out of the country of India, and primarily the parents who were polled for this study were had very low education and low socioeconomic levels, and they were asked what did they want for their child who had a cancer diagnosis that could be terminal. And what parents said that they wanted in this situation was to be able to obtain the information and to have clear communication with their care providers and to be physically present with their child. And that was their priority. And so if the country of India, who is able to study even their most impoverished patient families, can take into account that perhaps the paternalistic approach of projecting our biases might not be the best one, then perhaps us on the other side of the ocean could consider that this might also be a way of approaching these end-of-life care decisions with our patients. So, what is really going on in the brain during coma? I put up a little image of a cricket here because for a long time we didn't know. It was kind of like the silence, and then all you can hear is the crickets. But we've actually know quite a bit now about coma. And so here's the old definition of coma. Eyes closed and unresponsive to environmental stimuli. If it sounds like a cave woman just got up and said something to you, it's because I did. This is the old definition. And if you look at somebody in a coma, they are largely unresponsive and their eyes are closed in general. And so for a long time, that's all we knew about what was going on in the brain was that whatever is going on in your brain, it's causing you to not be responsive to the outside world, and your eyes are closed. Okay, great. So what is really going on in coma? If we look at the connectivity definition, which is from functional MRI, what we realize that there is a global neural workspace that has both local and long-range recursive processing loops. Don't worry, I'm going to go back over this. With cortical hubs, these are the places that are responsible for transmission of information, these hubs in the brain, which permit globally available information throughout key regions. So we have now a test at our disposal in our MRI machine that can show us what is going on in the brain of a person with coma. So we no longer have to guess, and we don't have to use the old definition entirely. Of course, that will still be our exam findings, but in order to determine exactly which disorder of consciousness a child has and what their likelihood of coming out of that disorder is, we can inform families about that. Now, of course, no test is perfect. It has its sensitivity and specificity, so there will be false positives and false negatives. And we can look at our receiver operating curves to understand those and also inform the families about this level of certainty and uncertainty, as with any test. So, currently, coma is misdiagnosed 43% of the time in adults, so it's probably higher in children, and it's probably even higher in neonates. Because when someone is unresponsive, they look the same as if they were in coma or if they were in a locked-in condition or they were in subclinical status epilepticus. So we can't tell just by looking at somebody which condition they're in, and if we don't know what their diagnosis is, it's very difficult to receive the proper treatment. So why are brain death and disorders of consciousness so difficult to diagnose? Well, there's very inconsistent behaviors that a person can display when they have such a disorder of consciousness, such as repetitive frowning. Withdrawal to pain can look like the same as triple flexion, which is only a reflexive response. If we say their eyes are open or their eyes are closed, they're determinant of whether or not they're in a coma. What if they have fluttering eyelids, or eyelids that are barely open, or if they have ptosis from weakness of their eyelid muscles, and on of these confusing bedside markers that throw us off on what is the correct diagnosis. And as I was saying, without a correct diagnosis, we don't really know if we need to be very urgent, such as hurry up, push mannitol, or okay, give an anti-seizure medication, or we need to send these labs, or being able to give consistent informed decisions or help with those, and give an accurate neuroprognostication. So it's actually critical to be able to do this. So I drew this little sort of paradigm, if you will, about brain health. So if we put overall cortical health, so that's the supratentorial thinking structures of the brain on the y-axis, and we say, oh, if you're healthy, you're up here. If your brainstem is healthy, rather, you're up here. If your brainstem is unhealthy, then you're down here. If your cortical structures are healthy, you're over here. So if you're brain dead, then your brainstem and your brain have very poor health, in fact, are dead. If you're in a coma, then you're over here in this quadrant where your brainstem health may be fairly good, but your cerebral health is pretty poor. In mixed brain injury types, you can have this pattern where the cerebral health can be declining in function and the brainstem health can be declining, but is still not brain dead. And then a locked-in individual generally has injury in the brainstem and fairly good health in the cerebral contents up here. So we need to know what quadrant our patient is in the ICU to make good end-of-life care decisions, i.e. to continue care or to wait for progression or to go ahead and redirect care toward comfort measures. So we have various tests that give us some information, but they lack the sensitivity and specificity that we would desire. For example, our bedside cranial nerve exam sort of extends, once we get down to, pretty poor brainstem health, then the individual looks more or less the same as when they're brain dead as to locked in and just pretty low-level brainstem health testing. So this sensitivity range is not so great. If we look at the bedside exam, once our bedside exam becomes to the point where we don't get response to environmental stimuli, then that's a very low sensitivity exam for diagnosis, okay? Same is true for EEG. Once we get slowing on the EEG and we don't have epileptiform activity, this test doesn't help direct us. And I would say one test that we can count on is the blood flow test, the SPECT, cerebral brain flow SPECT test, but the patient has to be beyond help at that point and has to be dead. So this is not a good test to know if we should intervene or continue. It already just confirms that they're dead. So to confuse the matter further, in any one of these conditions, the patient can be having subclinical seizures or increased intracranial pressure or hemorrhage or metabolic derangement that if we don't understand which condition they're in, it can be difficult to know if we need to do testing or repeat testing for any of these conditions. So, what do we know about resting state fMRI? To give you an idea of the amount of volume in the literature about this test, these is in the tens of thousands of publications over the last years in functional MRI compared to EEG. And so functional MRI has eclipsed EEG at this point in as far as informing on brain network health. and also level of knowledge that it can reveal about what's going on inside the brain outside of seizures. And just to kind of put you into the clinical realm, over here are the hundreds of clinical publications for neurodegenerative disorders, and so it is location specific for each degenerative disorder and is informative. All right, what about coma? So there are lots of publications about coma using resting state functional MRI. I'm going to kind of give you the headline here, and then you're going to hear me repeating myself over and over and over, because at this point we have dozens of publications that have been replicated in the literature and hundreds of individuals who have disorders of consciousness, and they all repeat themselves and have the same findings. So we have a level of certainty that this test is informative and relatively accurate in this situation, and at this point is more informative than any other test we have available. So, resting state does differentiate outcomes in coma. In this study, I think we can see it pretty well up there. They took 27 patients who were in a coma from anoxic and traumatic causes, and they showed that they had disruptive functional connectivity. So as we come over here, here's controls in the blue, those that recovered in the green from disorder of consciousness and coma, and those who only achieved minimally conscious state and those who achieved vegetative state. And so if we look at their connectivity of the default mode network, which I'll explain what that means in a moment, their connectivity actually linearly correlated with their outcome. And so let's go back over what is default mode network. So when we started using resting state functional MRI, we found this network that we weren't as aware of before called the default mode network. And this has turned out to be a critical network in consciousness and recovery of consciousness. It turns out that this network modulates all the other networks, major networks of our brain. The primary location of this network is in the posterior cingulate gyrus and is present in neonates down to 28 weeks of age all the way through to the end of life. And the only situations in which the default mode network is not detected is under general anesthesia and brain death. Here is the picture of the default mode network, and here's what the default mode network looks like as our consciousness is degraded in human beings. Here's healthy default mode network. Here is an unhealthy default mode network but still present, and here is a disappearing default mode network. If it's not detected at all, so far in individuals, as I've mentioned, they've progressed or already are brain dead. In this study, which was a separate study than the one that I first mentioned, the hash marks in the default mode network compared to the other networks separated out the individuals with different disorders of consciousness and outcomes. So in controls, these are different networks on the X and Y axis here, and this is their connectivity score between those networks. So here's the default mode network right here in controls. If we look over in those with favorable outcome, they still had good connectivity of their default mode network. So these are individuals who regained consciousness, and those with poor outcome did not have the normal or even halfway normal default mode network connectivity score. So we're fortunate at our institution that we have experience in individually interpreting children who've had, for the most part, a prior brain injury and went on to have intractable epilepsy or from disorders of consciousness directly during the time of their acute brain injury, experience in interpreting individual resting state functional MRI in children over the entire spectrum of neurodevelopment. And at no point in time did we have divergent data in which networks were not detected unexpectedly or vice versa. And so we have a comfort level in interpreting these tests in all ages at our institution. This is an Italian study looking at 100 patients with disorders of consciousness, and they essentially found the same thing, that the default mode network differentiated between those who regained consciousness and did not. And they used the same analytic techniques that we use here. And they recommended using this test in those in which diagnosis is uncertain at the bedside, which in my mind, is pretty much everybody who's in a coma or has a serious disorder of consciousness, because guessing isn't that great of a tool. Here's what the default mode network looks like from a different study that showed controls, locked-in syndrome, minimally conscious state, and vegetative state. And their proposal was also to use it to help confirm brain death. This was just a separate study after cardiac arrest, and it found the same thing. So it feels like I'm repeating myself, because I am. This was a really interesting paper. So this came out of Harvard and was presented this year at the Neurocritical Care annual meeting. And it's from the folks at Harvard. And what they're showing is this is a separate modality of diffusion tensor imaging. So DTI is thought to be an anatomical study. It's not using functional MRI. We're looking at what are the white matter tracts of the brain. What is their health? What is their current condition? And they looked at the white matter tracts in individuals who had coma. And they found that there were differences from normal in the brainstem in those who had coma, and they're showing you where that was in the brainstem here. Now, what's really interesting is these individuals who had these structural differences in their brainstem at the time of their coma recovered consciousness. So we largely think that structural differences in the brainstem are irreversible. And oftentimes we look at structural imaging, especially diffusion tensor imaging and diffusion weighted imaging of individuals who've had brain injury, and we look at their brainstem and we will say to parents, we think that because the brainstem is largely an irreversible area of damage that your child will not recover. And what we're finding is that's just not true. This is a study from the same group looking at resting state functional MRI and recovery patterns in those with coma, and it largely replicates what we've heard so far. And really, they're even showing that you can predict the time, how long someone will be in coma using their resting state functional MRI, which is a news flash to me this year. So this is actually an old paper because it's only listing about 30,000 individuals. We're up into the tens of thousands at this point, as I mentioned, looking at everyone's brain networks and seeing that humans pretty much all have the same brain networks. It doesn't matter if you're a 9-year-old, a 5-year-old, a 28-week-old. These networks appear and are present. They're never off, even when you're asleep. Or if you have a disorder of consciousness, they are still there if you're going to recover, especially your default mode network. And well, what do these networks mean anyway? So there are now hundreds of thousands of articles about what these networks mean and what do they do and what they're correlated with in very fine-tuned manner of what your capacities are, your executive capacities, your language capacities, and so on and so forth. So what is even more powerful about this tool is that we can say with some level of objectivity what recovery of consciousness is, but what about beyond that? Will your child be able to understand language or speak or walk? You know, things that parents might be interested in knowing or may not have the resources to care for their child if these capacities aren't there. So having some level of objective information to be able to tell the family, I don't know if your child will recover, we're in the uncertain situation. These networks are still existing at your child at this point in time, so it may be reasonable to wait. Or these networks are not here or seriously degraded, and so we have less certainty about your child. And this is the objective information that parents are reporting that they would prefer from care providers. So what about the integrity of the signal of the bold is the blood oxygen level that resting state is measuring. And so there's some fluctuation up to 3%. So this is a very robust signal in general. And well, what are our current consensus guidelines from our expert organizations are saying that the American Academy of Neurology, and this has been since replicated by other professional organizations, saying that when bedside evidence is lacking, that it's reasonable to use a functional MRI studies to help understand what is going on with your patient. Okay, so let's dive into the pediatric data. So as I said, around 28 weeks of gestation, these major cortical networks become detectable. We know this because after babies were born at prematurity, they were scanned and we detected their networks, we as in the scientific community. And by term, you can see a fairly adult-looking networks, although they do develop over time, but they are detectable. These two studies are just to help illustrate what do the changes look like over development. Here's 1 month all the way up to adult, and you can watch the motor network changes over time or any other network you're interested in. Similar slow by other investigators. So we understand what the developmental differences are in normal individuals over time over the course of neurodevelopment of these networks and what those expected changes are. Here's a study in 12,000 9-year-olds, 9 to 10-year-olds, showing that RS correlated with their cognition scores and other major neurobehavioral functions in the ABC study. So this was a multi-institutional study. Here's our team for the neurocritical care folks. And so in 2017, we rolled this tool out to all of our ICUs and made it available to all doctors at this institution starting in 2017, and since then they have used it quite a bit. This was the first patient to receive a functional MRI in our ICU. His name is Ammon Gibbons, and his mother is here today. At the time of his functional MRI, he had a disorder of consciousness, and he was largely unresponsive. As you can see, he has a feeding tube in his nose and a machine controlling his airway and much of his breathing function. Ammon developed his disorder of consciousness on the day that his brother died. He became so distressed when his brother died that he developed a bleed in his posterior fossa. He came to Phoenix Children's Hospital, and his heart was wavering in and out of being able to beat on its own, and he went straight to the OR and received a decompressive posterior craniectomy. So we removed the back of his skull and the hematoma from the posterior fossa, which is the bottom portion of the brain. At that point in time, the hematoma was compressing his brainstem, and he did not have brainstem function, and that is why his heart was stopping. So he wavered in and out of death on that OR table, and his life was saved by that posterior craniectomy. But then he stayed in our ICU for 2 months, looking more or less how you see here. And our care providers could not tell that he had any level of consciousness, nor could I myself as his care provider. And because we didn't know that and he seemed unresponsive, the care that he received oftentimes didn't include pain control or respectful comments about his neuroprognostication in his presence. These are measures that we've discussed amongst ourselves of how we can improve our care, because oftentimes with disorders of consciousness, we don't know if the person can hear us or not. So here's Ammon today with his family. He's enjoying a roller coaster ride, and he's back in his regular school classes and is on track for college and a technical degree. And I think very much he enjoys life. So here's what his anatomical MRI looked like after his posterior craniectomy. He had differences in diffusion-weighted imaging in the posterior fossa here, and then also somewhat diffusely you can see there are these brighter areas in the deep areas of his brain. Some are along his cortex, but largely there was normal signal out here. But we didn't know why for 2 months he didn't improve, and our palliative care service offered redirection of care to his family toward comfort care measures. And so if we try to put Ammon somewhere on this chart, we would say, well, we don't really know, but he's somewhere in the middle based on the information that we have. We don't have a good diagnosis for him. But when we did his resting state function MRI, what we saw is that all of his major cortical brain networks were intact, including his default mode network, and all of his cognition and speech, vision, everything was there, and it actually had normal signal. But then he had these abnormal signals that came from his ventral medial prefrontal cortex, the deep structures of his brain, and his mesial temporal lobes. These time signal of his bold signal there from these areas was consistent with what we saw with children who had intractable epilepsy. And that's in comparison to his normal cognition networks that you see down here, which are slower in frequency. So we treated him as if he had subclinical status epilepticus. Now at that time, his EEG only showed slowing, no epileptiform activity. So we were guessing about that. But it's not unusual for a resting state function MRI to show differences consistent with seizure when the EEG doesn't show it. Because the EEG tests the last few millimeters of brain for epileptiform activity, whereas the resting state has no such spatial limitation. So we gave him phenobarb, high doses, for about 3 days, and then after that he woke up. So based on that information, he fits squarely in the locked-in syndrome category because he had default mode network intact and all of his major brain networks intact in this subclinical seizure. He was probably intermittently aware, which after he woke up, he reported things that indicated most clearly he was aware during a good portion of that time. This is him today, and he will be singing, and you are all invited, at the Phoenix Boys Choir event this Saturday at 5 p.m. If you'd like to watch Ammon singing with his choir, come on out to the Central United Methodist Church. I don't get any proceeds from this. How about those neonates? Just showing you a little flash of what language networks look like from some children in our ICU who've had a mild hypoxic encephalopathy. So we've been applying this standardly to all children in the neonatal ICU who've had a hypoxic ischemic injury related to birth for about 2 years now. And I don't expect you to be able to read this, but our first study is coming out from the outcomes of this data, and it will be the first of its kind in the world. In the sense that it reports how well this correlates with outcomes in the short run, including recovery of consciousness and capacities at the very young age. And what we're finding, as we did this on a data-driven manner, meaning we tested all networks and correlated all networks with outcomes, as opposed to saying, well, I'm only going to look at the default mode network and see how that correlates. Well, we looked at all of them. And to our surprise, we found that the basal ganglia network correlates with all kinds of things related to the child's outcome and the recovery. The long range, these are the cognition networks. If they weren't there, they predicted actually death in that child before they died, and as did the default mode network. So that's pretty powerful. As far as the seizure sources, they interestingly predicted developmental delays in motor tone, but not so much seizures in the long run, which after an acute brain injury, we do generally have a pattern of difficult to control seizures in the first 2 weeks, which doesn't necessarily mean that that child will go on to have epilepsy, but it's interesting to see that it does correlate with early developmental delays. This is the first neonate in the world to have resting state correlate with death prior to that individual dying. And this is what their anatomical MRI looked like at the time after birth. So there was diffusion restriction in the deep centers of the brain, but largely the cortex was normal. This sounds a lot like how Ammon's MRI looked. So diffusion-weighted imaging in the acute period can have findings that still leave doctors without enough objective information to predict their outcome. Below is a summary image of his resting state function MRI of all levels of his brain, showing no networks and only cardiac pulsation through there. This individual developed full body extensor tonic posturing and passed away days after this exam. I'm just going to mention that when we look at an individual who has experienced brain death and that they undergo an autopsy and we send those slides off to the specialist, what they will see is that between 30 to 66% of the cells have died. But that means that somewhere between 30 to 66% of the cells were still alive at the time of death. So in brain death, not every cell has died in the brain. What brain death is lack of function. It doesn't actually mean every cell has died. So if we wait till every cell has died, our ICU would be full of individuals waiting for all the cells to die. Instead, we declare someone brain dead when all of their function is gone. And it can be very difficult to understand if all the function is gone if we don't actually test for function, but we only look for brainstem reflexes, which can be reversible, as we now have confirmed undoubtedly. So let's see if this works. My mouse is on like pointer mode and it won't let me hit the video. Let me see if I can do it. Here we go. Well, I'll just let it go. So essentially what I have is a video of a chicken being beheaded. After this chicken is beheaded, it flies away from its murderers. It does all kinds of really amazing behaviors. And the reason I show that is because there's a lot of artificial intelligence that goes on in the neurologic system outside of the brain. And when we walk into a room and we see a patient squeezing a hand or kicking their leg or even sitting up, opening their eyes, there's just all kinds of behaviors that individuals can have even though they're in the process of dying and are in an unrecoverable state, or they might be actually doing that because they intend to. It can be very difficult to differentiate. It can be hard to tell if they're in pain or not in pain. This is just sort of a second illustration of that sometimes the bedside exam can fool you. Actually, very often it is. But we know that for sure this chicken is dead because it was beheaded. And if we looked at all those cells under the microscope right after beheading, the pathologist would tell us, well, at the time of death, a lot of these cells were still alive. And if we looked at, even the EEG recordings, even after death of that brain, that there would still be slowing on the EEG. So if we look at EEG publications after brain death, in about 20% of individuals, there's still ongoing brain activity because the EEG is not a test of brain network function. It's just a test to see if the cells are still alive or not, which is actually not a good measure of death. That chicken is brain dead. So this was the first baby to receive a functional MRI from the cardiac ICU. This child has transposition of the great arteries and had a multifocal embolic infarct primarily involving the right hemisphere, but also the left. The EEG of this individual showed low amplitude and involving seizures. The parents of this child were very clear. They did not want to take home a multiply handicapped child. And so by those current standard tests, this child would be somewhere in this category between coma and mixed brain injury. So it sounded like we were in the category of what the parents were fearing. We did a resting state functional MRI on this individual, and what we could see surprised me, that there was bilateral leg network activity still intact, some part of the hand network, the face on the damaged side of the brain, and the full entire motor network intact on the left hemisphere. So by this individual should be able to walk and have full use of the right side of the body and a helper arm at minimum on the left arm. These were the language networks of this child, were still intact and healthy looking. Secondary sensory networks still intact. Cognition networks on the left side of the brain still intact. Bilateral vision, primary and secondary visual networks still intact. And even some of the temporal, secondary temporal association networks still intact on the largely damaged side of the brain. And these were the seizure sources of this individual, largely coming from the right frontal hemisphere, which was also detected by the EEG in this individual. We treated this child aggressively with anti-seizure medications, and that child eventually had seizure control. By resting state functional MRI, this child does have a mixed brain injury and a recoverable condition. So over the next 10 days, this child remained in this disorder of consciousness. And, oh, I'm sorry, this is the other child. Let me skip that. So this is a summary of the cases that I reviewed here. We have many other cases. I can't really go over all of them in this time period, but you can see that in general, this neonate that progressed to brain death, this child in whom we thought originally may or may not recover from coma, and this child who was thought to be in unrecoverable condition did recover, and these we were able to tell by resting state functional MRI and by no other test. This is a child. Actually, I want to mention this child. As we know, all tests have a sensitivity and specificity. Resting state functional MRI sensitivity for disorders of consciousness is 0.8. So this is higher than any other test that we have right now, but is not perfect. So in this case with this child who drowned and had a cardiac arrest, came in initially with fixed pupils and post-anoxic status movements, and was treated for seizures, and had evolving EEG that eventually had no seizures, and had this really what I'm going to call abysmal structural image, in which the diffusion weighted imaging showed positive findings in the bilateral deep areas of the brain, and then here and there in the cortex. And this individual was thought to be potentially brain dead or in a coma at the time of their resting state functional MRI. And the resting state functional MRI did show default mode network with normal time signal and also long-range networks. It was really tough for me to believe even because of how bad the child looked at the bedside. This child did recover all brain stem reflexes and did recover consciousness and is awake. But at this point in time, so these are also seizure sources that were detected. When I saw this child, he was no longer seizing on the EEG, and he had pupils that were in and out of responsiveness. And I did deliver this news to our care team and sort of left it to them as to decide what they should or shouldn't tell the family of this objective information. And we temporarily started to wean his valproic acid when he was in the ICU, and when we did that, we lost his pupil reflexes, so we put it back on, even though we didn't have other evidence that he was still seizing. And he was maintained on 2 anti-seizure medications, and now 2 months out, he still looks awake and has brainstem reflexes, but is still unresponsive to us. This is now 2 months out. And we weaned his valproic acid again, and he lost capacity for independent breaths and required continuous BiPAP and came back to our ICU. So as of right now, he hasn't received another EEG or another resting state, and he's on continuous BiPAP. At this point in time, for this case, it might be considered to repeat an EEG or a resting state functional MRI to see how his brain networks have evolved over time. So this is not necessarily just a one-time test, but a check that we can do serially over time. So when we get a resting state report, we receive information about every one of those brain networks, and it's a long, wordy report, and it's broken down by network, what that network does, and if it's normal or abnormal in that individual at that point in time. We can say about those long-range connections between the frontal and parietal cortex that in individuals in whom that's intact, their IQ is generally over 75, which is considered largely toward the normal range. So that child at the time, 2 months ago, with that default mode network intact is probably over here in this category. So since our current tests are largely unrevealing in coma, and we have a plethora of published evidence patterns in coma by resting state and neuroprognostication information in adults, children, and neonates, are we ethically obligated to use resting state since it's more informative than our current standard of care? I would say that if you asked a parent whose child is experiencing a disorder of consciousness, would you prefer that your child receive this objective test and you hear that objective information, or would you like to hear our biased reports and guesses? I'm just going to say, I have about 5 minutes left, we went through a similar odyssey with children who had drug-resistant epilepsy and resting state functional MRI over time. And what you're looking at is the first live seizure on resting state functional MRI from the mesial temporal lobe of a child that the seizure was not detectable on EEG. We put a depth electrode in that area, and lo and behold, there was nonstop continuous seizure activity from that area of the brain. And so this gave us some level of objective evidence that we should probably be doing this test in every single child who has drug-resistant epilepsy and might be a surgical candidate, which is the only known cure for drug-resistant epilepsy. And so what we found with this first generation of testing was that there was about a 78% accuracy and 93% specificity for this test in localizing seizures, regardless of what the other tests showed. And what you're looking at is just a demonstration that resting state can find seizure sources regardless of location, no matter how deep in the brain they are. And this is a child with a hypothalamic hamartoma, in which we found that we can use this test to help aim lasers into the brain and know where to disrupt the network in a child with a very deep source of seizure and cure that epilepsy. This is now pretty much a day surgery, and the child goes home the next day cured from their epilepsy.
Perfect.
All right. So with this next generation of testing, what we found is that we increased the cure rate of epilepsy by 45% using this technology, and we drove the accuracy up to 95%. We recently published in the Annals of Neurology repeat serial testing of resting function MRI does correlate with cure of epilepsy. So this is the seizure source prior to surgery. Here's what our anatomical MRI showed us, was that there's this little dot that we should probably laser. When we went after just that little dot, the child's seizures were not cured and not really substantially reduced, probably because there's a network around it, and it's not just the dot that we can see on the MRI, which is what this target lesion shows here. When we actually lesioned this entire area, or as close to it as we can, about 80%, we found that the signal sources, the networks in that area, then normalized, and that correlated with cure. And this was also had a 94% accuracy. So what we have now in press is, what is the impact on care of resting state functional MRI? So what we're expecting is that the national guidelines will change over time because of publications such as this, in which we demonstrate that 13 more surgeries happened out of a group of 50 individuals evaluated for surgery that otherwise would not have occurred. And so we have the chance to cure about 26% more children using this test above and beyond what we were doing before. So in summary, Using resting state after an acute brain insult, we can see that the default mode connectivity does unequivocally correlate with recovery from coma, and this is better than any current testing. And I just want to point out, there has been no other test on the face of the earth or in the history of mankind that has so many individuals tested before it was rolled out for this very sensitive population. So our objective, we now have objective evidence to help guide us into whether we should advise watchful waiting or redirection of care toward comfort measures, better probably than guessing. And we can comment on objective information related to potential for cognition and functional skill detection for neuroprognostication in these situations better than our current standard, which is mostly guessing. And we can identify signals that are abnormal from deep sources, which no other test at this point can detect. And resting state is unequivocally an improvement over our current methodology and prediction of recovery. Thank you. This is my labs team and our new postdoc, Bethany Sussman, who's working on all of these types of studies. Questions?